Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on HealthcareNOW Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world. From border to border, coast to coast, and to all the ships at sea, I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in to the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology. Our mission is simple and always the same. We're searching for beneficial disruption in healthcare from emerging technologies. I'm really pleased today. My guest is Matt Fisher. I've known Matt for about 4 or 5 years, and I always like to get his observations. Matt is an attorney and a partner with a firm of Merrick O'Connell, and he focuses his legal practice on health law and really all areas of corporate transactions. Matt advises clients on regulatory, fraud, abuse, and compliance related issues. He's very active on social media and is also, as I do, has an internet radio show which is entitled Jure, where he delves into healthcare issues from a legal point of view, which is always interesting. That show can be located at HealthcareNOWradio.com. So, Matt, welcome to the Tate Chronicles.
Well, thanks, Jim. It's nice to be on with you, and kind of as you said, it's nice to be on another broadcast within the HealthcareNOW Radio network.
Yeah,
so I'm looking forward to talking with you today.
Yeah, it's good to catch up. We cross paths certainly a lot on Twitter and other social medias. Maybe once a year we see each other at HIMSS or another conference, but glad to have a little more in-depth conversation.
I definitely agree.
Yeah, if you don't mind, I'd like to back up a few steps here, Matt, because I always want to know when I talk to people. The fact that you've been involved in health law for quite some time, what led to your interest in this part of the legal profession, healthcare?
So getting involved into the health law field was actually completely inadvertent and unintentional, which from my perspective actually made it the best way to go about getting into it. Going through law school, I didn't have any particular focus or thought on an area that I wanted to go into in terms of legal practice. In fact, I actually went to law school because I intended to go work as a legislative assistant or legislative aide for a member of Congress or potentially on the state level. But then, through the quirks of life, ended up landing at my firm and finding that, I actually had no idea what it meant to practice law in a law firm. And once I got to my firm, first as a summer associate and then full-time, I kind of figured out, hey, the actual practice of law is pretty interesting and a lot of fun. So kind of in conjunction with starting, I got very lucky in terms of, my firm didn't have a particular focus or, anyone practicing within the health law area, but we did have a number of clients that were healthcare entities and, firmly entrenched within the industry. So right around the beginning of my time here, started getting fed assignments to do some regulatory research, which I think at that time kind of focused a lot on fraud and abuse issues, like the Stark Law and the anti-kickback statute that govern referral relationships among providers or other entities that might be able to bill for a product or a service. And then also kind of into state regulatory issues around licensing and other requirements impacting operations. But kind of through all that experience, very quickly, I would say I determined that it was a very interesting area of the law to be involved in, and one where the pace was really starting to pick up in terms of change. Because, as you said, it's been a little bit of time, but that beginning period of time for me was in 2008. So it actually predates the ACA by just a little bit, but kind of allowed me to start learning stuff as the ground really started to change and shift within healthcare, which at the time, when I started attending legal conferences dedicated to health law, people were saying it ended up being a great time to get in because a lot of people were being shifted back to square one, while the regulations around like Stark and anti-kickback and HIPAA, which I'm sure a lot of people out there know about, while those didn't change, the way it was being applied and some of the models that were being pursued were changing. So it really kind of removed a potential handicap in terms of being someone new to the field. So it allowed me to get pretty interesting experience right from the start. But kind of as I said, it was, all that was very inadvertent and unintentional, but I was also then lucky enough to have my firm support me once I determined that this was a fun field to be in and where my passion ended up being, to be able to pursue development of a more robust and complete practice. And at this point in time, I now am lucky enough to be able to have probably 90+% of my time working with clients that are in the healthcare field, whether it be clinician type organizations, hospitals, nursing homes, or digital health companies and other types of consultants supporting the field.
Well, a couple things that you mentioned there, Matt, make me come to this question for you. So what were in terms of your practice and what your clients are concerned with and dealing with and worried about 5 years ago as opposed to now? What trends have you been seeing about things that I imagine 5 years ago, Stark and HIPAA were very, very big things. I know they're still kind of big, but I'm sure there's some new trends that have kind of risen their heads that you're being called in to address and educate and provide clarification on. What are some of those new things in health law in the last few years? Yeah,
so to answer that question is really to, I think, break down the types of clients that I work with, because the concerns are definitely varied depending upon which segment of the industry I'm working with. So taking the clinicians and the facilities first, kind of a constant thread throughout is always fraud and abuse, because the fraud and abuse laws influence how service agreements or other transactions can be structured. I think as kind of consolidation and merger activities have increased, or certainly, I guess maybe within the 5 years, I would stick with increase there. They just keep always going up. How you can make sure that those are aligned appropriately, are very much driven by fraud and abuse. So that definitely remains a top concern. The other big one, which so I'm up in Massachusetts, so we were kind of a little bit on the forefront of this, but I think things have also still accelerated over the past 5 or so years, are value-based care models. So connected to that are how to frame contracts with commercial health insurance companies, because certainly up here, and I think this is probably borne out nationally as well, it's not just Medicare that is trying to implement value-based care models like an ACO or bundle payment, but we're seeing that up here as well on the commercial side. So working with my clients in terms of negotiating those contracts with the insurance companies has become a pretty big concern. And then, I think just keeping up with privacy and security issues. There's been, I'd say, a little bit of change on the state law side of things, but it's, just making sure that they're doing all that they can to secure the information entrusted to them, since I think security attacks or cybersecurity attacks are on the rise, and it is certainly an overarching concern.
No, I want to delve deeply in just a minute on the ransomware and cyber attack, because that's certainly a new thing. But you mentioned value-based care, and so do you have much involvement during mergers or acquisitions? Maybe a hospital is buying a private practice, medical practice, and you're representing one side or the other. Is that part of the work that you do?
Yep. So I will. So I'll definitely work with, and it's usually more on the physician side of things when they're being acquired. And from that perspective, I think it's the value-based care is a factor in it because of the perceived or actual increased burden from the administrative side of things in terms of being able to keep up with the requirements there. It is definitely a reality that there is a lot more paperwork, whether it's physical paperwork or electronic filling of forms, but there is a lot of stuff that needs to be tracked, and just adds to kind of the headaches.
Sure.
There is also some of the degree of if you've got a smaller physician practice, there is a perception of if we're not part of a larger organization, it's harder to try and manage some of the risk that's trying to be pushed onto the organizations as well. Because if you got a bigger patient population that you can spray it across, then it makes it a little bit easier to weather a couple of bad instances. Whereas if you're a small practice, one or two negative outcomes or costlier patients than anticipated can quickly put you down into the red financially.
One specific question, I'm curious as to whether you've had to address this yet, Matt, is under the macro MIPS rules and legislation we're under now, where practice with a very heavy Medicare Part B reimbursement, maybe not in one of the accountable care organizations, but just purely has exposure to Medicare Part B reimbursement. And depending on what their MIPS score is, has a direct correlation to their income and the value of their practice if a hospital wants to acquire them. Now, the initial and that yearly MIPS score has not kicked in yet. We're kind of expecting them any day for a reporting year, the year before last. But is anybody concerned about that or talking about the value of a heavy Medicare Part B practice going up or down as far as when they're acquired based on that MIPS score?
I honestly don't think I've had that come up as a direct issue. I suspect that it's probably wrapped into broader concerns about the distribution of the patient population across the different payers.
Sure.
I know there's been kind of some newspaper articles or reports that have come out recently talking about prices that are charged or reimbursed by different types of payers, whether you're talking about Medicare, the different Medicaid programs across the states, and then commercial payers. But I've always understood kind of the general rule, and this was certainly something echoed by the CEO of local hospital system for me at a local conference in the past year or so, which was, you want to see the distribution of patients of roughly a third across each of those types of payers, since Medicaid is typically reimbursed below expense, so they're just flat out losing money with Medicaid. Medicare traditionally has arguably been a break-even proposition, although now I think I've been seeing more assertions that Medicare may not actually be keeping pace with the actual cost of services, so it's potentially that's starting to bleed down into the red. And then you actually make money with the commercial insurers and still pay. I think it's usually I typically hear at least like around 150% or so of Medicare. So I think to your question, if a practice is going to start seeing penalties or reductions in their Medicare reimbursement because of a MIPS score that is too low, I think I definitely believe that will have some type of an impact on the financial viability of a practice, and could further drive more consolidation. In my market where I am, there's already a large degree of that type of consolidation. We don't have all that many small independent practices anymore. I think you've got a bunch of different groupings, and then given all the hospital systems or significant hospital systems that we have, even if you have an arguably independent practice, they can join kind of a larger community network connected to one of those major systems and get the benefit of contracts through there and other kind of administrative support. So it's I think on the whole, the experience that I get to see in Massachusetts is probably atypical from a number of other states, and it's and I think also broadly speaking, our population centers are a bit more condensed. We do have some rural areas, but comparatively small ones if you're looking at some of the other states across the country.
Yeah, and of course that ideally having that patient population mix spread out. For some practices, it's possible. If you're a pediatrician, you're not going to have any Medicare Part B probably. And if you're maybe a cardiology practice, you're probably going to have a higher percentage of Medicare Part B. So I know it's going to fluctuate depending on whether it's a specialty or not. But let's hop to another subject you mentioned earlier, Matt, that I'm going to just go ahead and jump in with both feet. That's cyber attacks and ransomware. Have you been directly involved in any of those cases yet, or what are you hearing from folks in the legal industry about it?
It is definitely a top concern and one that requires constant vigilance. And I think it's also a concern that really goes outside of healthcare as well. It's kind of my belief that we hear more about the issues within healthcare because healthcare is one of the few areas where you actually have mandatory reporting when you have a breach. Most other industries, they don't necessarily have to disclose that an attack has happened. So it's, I think that is a layer on top of it to always consider. That being said, I think it's helpful to know when an issue like that has happened because then it provides more industry awareness and knowledge about the threats. But kind of in terms of specific issues, they are occurring. I've had some clients talk with me about concerns. I know, frankly, within my own office, our head of IT and who's also our head of security is always assessing threats to our system and working to make sure that we've got the system locked down enough that we're not going to have a breach. But I've also talked with others where they were starting to respond because they either got locked out of their system or they detected some type of an intrusion. So when that type of thing happens, first, it's always good to have had an incident response plan in place ahead of time, and not just have it in place, but to have people familiar with it and to test it and to be ready to run with it. So that way you're not scrambling to kind of figure everything out once the attack has occurred. And that really should involve a nice collaboration and cohesion among actors internal to the organization, as well as getting appropriate consultants involved, which could be the organization's attorneys. I think some type of a security firm that is more familiar with the technical side, because I will very freely tell my clients and other people that I talk to, I know the law, but I don't know how to actually get into your system and help you stop an attack or to do a forensic analysis to determine what, if anything, may have been accessed when the attacker was inside. It's, I can definitely point you in the direction of the people who can help with that, but it kind of goes to everyone has an appropriate role to handle. The other piece of it is just being proactive. I always like to remind clients that for purposes of HIPAA, you have to do a risk analysis, and it's not just a one and done type risk analysis, but one that should recur frequently, and certainly at least on an annual basis. Although I would strongly suggest that you want to be doing kind of piecemeal assessments throughout the year as threats change. So when you're talking about the cyber attack side of things, it is really an issue that is ever present and requires attention at all times.
When we hear the word cyber attack, we think of some bad actors in a foreign country, and they're in a basement, and there's 50 of them in front of computers, and they're doing all these really sophisticated things. Sometimes these cyber attacks are the simplest things on earth. I get these so-called phishing attacks every day. You probably do also. Let's say your bank account, something has happened, and you need to log in to make sure it's okay. And you log in, and they've captured your user ID and your password, or you get an email that says, I've seen strange pictures of you on the internet. Click here to view them. Okay, over half the people are going to click on that link. In the political world, Hillary Clinton's so-called cyber attacks was just a phishing email like that somebody clicked on, and malware was downloaded. So it can be very, very simple. It doesn't have to be some giant computer expert at all. It's training of a staff is certainly important that if they're connected to the internet and they click on an email link, that could be all she wrote. And so, these can be very, very simple things that can be very destructive. But let's talk about ransomware, because from time to time I hear about some hospital whose system gets locked up unless they pay some cryptocurrency or some Bitcoin, and they receive advice of go ahead and pay it. Have you heard those kind of things? What does the FBI tell us to do when a hospital receives a ransomware and their system is or their files are locked up in some way? The official government response.
Going to kind of your question about what does the FBI say first, it's, the isolated advice there is, you don't want to pay the ransom because that's just, arguably going to encourage more attacks because, the reason you see so many attacks occurring is, these attackers don't necessarily expect everyone to hit, and frankly, they really don't expect that. They send out so many that all they need is a small percentage of them to hit and to get paid that to make it worthwhile, especially because, I've read reports that, just like you have software as a service, there is ransomware as a service, and, the ready availability of these malicious codes has made it so that so many different people can run the attack and try to get into the system. That is, as I said, the advice in isolation. The reality is, if you're a hospital or a healthcare provider and you're locked out of your system because you've suffered that ransomware attack and you're not able to recover your files from a backup, which hopefully you have in place, since you have to remember backups are a requirement under HIPAA and really just arguably a best practice when it comes to electronic systems. But if for some reason you're not able to recover your data on your own, then you have to look at the practical side of the situation, which is, should you just pay the ransom in the attempt to get the data back? Because if you don't, you could end up in a situation, which, this is probably the extreme example, but that small physician practice up in Michigan, which had no backups, decided not to pay what sounds like a relatively modest ransom because they said, the advice is don't pay it, and they ended up with having all their data wiped away and they had absolutely nothing and they just shut the doors. I think that can be a potentially dangerous route to pursue because there then raises a lot of unknown potential legal liability for a whole host of different types of claims. So as I said, it's really easy to say don't pay a ransom because it just encourages the attackers, but at the end of the day, you have to look at what the specific circumstances of each case are, and look at what is really needed in terms of trying to make sure you can continue with patient care, because we look at the financial and the operational impact, but we always in healthcare, it's always helpful to keep in mind that everything that we do comes back to how can we provide services to and help keep individuals healthy. And if you're getting in the way of that by just following the isolated advice of not paying a ransom, then I think that needs to factor into the decision-making process.
I agree. It's a complicated answer. There's no one way to do it. I can't believe how the time has flown, Matt. We only have about 3 more minutes, so I've saved one of my strongest questions for last. Who owns healthcare data? Who owns my data?
that is always one of my favorite questions because there's so much debate about it. And to me, especially from the legal perspective, I don't necessarily care about ownership because ownership can always be played around with. If you think about it, even if you own, like, say, your house, that can always be taken away from you. The ownership can always be taken, the best example is by the government for what is perceived to be a greater public purpose.
Sure.
That arguably is no different than what could happen if every individual, quote, owned their healthcare data. It could just be, okay, you own it, but the government's going to say, well, you own it, but we see all this greater public health need to have, say, researchers have access to it so they can try and find a cure for a disease, or try and track epidemics or any other issue, and you're going to start having an erosion of that ownership right. I think the bigger and the better focus is on access and arguably control. Access means actually being able to get to the data and have it be given to you. That right already exists. It's clearly built into HIPAA. It's just that it's not always followed as it should be. So I think that comes down to better education, better training, and better transparency among everybody. The control one, I think that's where you start having a lot more nuance. I think if you free up the access, that could in turn help with the control issue, because if you allow the right people to have access to their data, then it changes the discussion around control.
Yeah, that makes total sense. We could spend an hour or more just talking about that. Boy, we're totally out of time. We got to go now. To our audience, thanks for joining me on this episode of the Tate Chronicles. I offer a special salute to my guest, Matt Fisher. Matt, thanks for coming aboard today.
Well, thanks, Jim. It was my pleasure. And as you said, the time certainly flew by.
If somebody wants to reach you, how can they contact you?
Yep. As you said, I'm on social media a lot. So Twitter is at Matt with 2 T's _R _Fisher. And that's just FISHER. You can find all my other professional contact information on my firm's website, which is myrickoconnell.com, and it's MIRICKOCONNELL. And I think between those two, you can pretty much find all the information you need to be able to reach out to me.
Yeah, that sounds great. You can find more information on this show's program page at HealthcareNOWradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.